Gutierrez and I were just talking about. You know, if I took an EKG right now and handed it to the majority of the staff, hey, they're gonna be like, let me take a look at this right now. Okay? Because they don't look at them every single day. Okay? But today we're talking about rate in the beginning of rhythm, and then after this we're gonna go into start getting into specific rhythms. Some of those rhythms, a lot of those rhythms are what I talked to you about, is memorization, like this is a rhythm. Atrial fibrillation is irregularly irregular. You've got to memorize it. I mean, that's just what you memorize. You're like, okay, I know about AFib, it's irregular, I don't see P waves. But today we're talking about rate and rhythm, and then we're going to start talking about specific rhythms in our next couple of lectures. And those are going to be fairly intense, so make sure that you have any questions. At the end of the lecture, either text me about it, email me about it, come see me about it, so we can get a good understanding of those rhythms that you're going to see. Let's start off with a little bit of a joke. I know you guys love my jokes, I can tell already. Okay, so what did the ECG machine say to the heart? You're my main squeeze. Oh, sweet. Let's see here. Hold on a second. Let's see. Let's see if we can get this together. No? It's not working.
I could never replace it. Oh, you're 8.
There you go. All right, very good. So our rate and rhythm basics, that's what we're going to talk about today. We've got our TLOs and our ELOs. This is still not what I'm looking for. Why is this not coming up right? Hold on a minute. Why?
That's such a good word.
Okay, there, now I think we got it. Okay, so I thought this was a cute little meme too. This EKG shows that the company is doing excellent help, right? On this day in history, did y'all know Coca-Cola has been around since 1886? Who knew that? And what kind of Coca-Cola person are you, if you're a Coca-Cola person? Are you like Diet Coke, the original? The Mexican Coke.
Oh, yeah.
Right? Like, I really didn't know what that meant. My nephew was in a terrible car accident last year, and I went up to see him, and I said, how's it going? He's like, you know what I miss the most, and what's bothering me the most? I said, what? He's like, the Mexican Coke. So I'm like, what are you talking about? But apparently, Mexican Coke is made different, right? It has real cane sugar in it. So it's like, yes, it's like totally addictive. So, I grew up on the original Coke, and I do like the original Coke, but I don't even drink Coke anymore. 1970, 1970, you're early born. The Beatles released their album, Let It Be. You guys, one of their most famous, they have lots of famous songs, but that's one of their more famous songs. And then Harry Truman was born in 1884 on this day. All right, let's go. Our fact or fiction. Campbell, Andrew Campbell. Okay, CPR does not require mouth-to-mouth breathing. That's fact or fiction? Where you at?
It's right here. It doesn't require it. Needs to use a back valve.
Does not require, right? Not anymore. Here, you got one? Oh, that was a perfect throw. Does not require anymore. Matter of fact, they did a huge study of several thousand patients, like 27,000 patients were in that study, and they evaluated compressions only versus how we used to do it, 15 and 2, 15 and 2, right? 15 and 2 or 30 and 2, if you know, before you were born. Okay, that's how we use it. 15 compressions, 2 breaths, 15 compressions. But now it's chest compressions at a rate of 100, right? And so you do not require, that is true. What about Castaneda? Elena Castaneda? Okay, ma'am, what do you think? Fingernails grow at different rates. Think that's true or false? That's true. How'd you know that? Did you guess? They do. Which fingernail grows faster?
Thumb.
The middle finger. I was going to show you, but the middle finger actually grows faster than the rest of the fingernail. All right. And then this is those were kind of just joke questions, but this one, your patients will ask you this all the time because they'll stand up, they'll hit their head on something, like a cabinet or something, and you should keep adult patients with concussion awake and then wake them up through the night. True or false? Let's go with Palinar. Palinar? How do you say it? Palinar? Palinar. What do you think? Do we wake them up? Make sure they're okay, make sure they have no altered mental status. True. Used to be true. Used to be true, so you're half right. But nowadays, and actually for the last several years, they say as long as their GCS is okay, you can let them sleep, and you actually should let them sleep because that rest is what the brain needs. Okay, so no longer do we need to wake these patients up, and it's actually adults and pediatric patients. You don't need to wake them up. Let them sleep. We want to have, reduce their time from screen time, no TV, let them sleep, let them rest, and that's what the brain needs to heal up from these concussions. All right. All right, our TLOs and our ELOs for our rate. Let's do a couple review questions. Which of the following numbers points to the PR segment? Bevins, what do you think? 2? Where you at? Number 2, right here, PR segment. What is number 1? PR interval, very good, okay? And then we've got this review here, okay? So let's look at this middle one here. I'm going to say that's the anterior portion of the heart. What leads tell us about the anterior portion of the heart? Sanchez. James Sanchez. Not 1 or 2, but V3, V4. V3, V4 tell us about the anterior portion of the heart, okay? Of the anterior wall. What about this? If I tell you this is our lateral part of the wall. What do we have for our lateral? Tran.
Say the question.
I can. Right here. Lateral portion of the heart. Which leads? Look at the lateral portion of the heart.
B5, B6, and 1.
and
ABL.
ABL. 1 ABL, V5, V6. Everybody agree with that? Here you go, sir. Okay, 1 ABL, V5, 6. That bottom one, that's the inferior portion of the heart. Inferior portion of the heart. Nevius. What leads? Look at the inferior portion of the heart.
2-3 ABF.
Yeah, that's it. 2, 3 ABF. 2, 3 ABF. Gotta know those things. Gotta know all those things, okay? And then this top one, the septum, okay, we got V1, V2, AVR is gonna give us more of that right part of the heart and the upper portion of the intraventricular septum. Okay. Every single time you read an EKG, you must have a deliberate approach. Every single time. Okay, you can come up with your own approach if you want. I don't care, but read the EKG the same way every single time. This is the way that I was taught 30 plus years ago. This is the way Dubins teaches. So rate, rhythm, axis, hypertrophy, infarcts. All of this is based also on your clinical correlation, and if you're lucky enough to have an old ECG, you want to compare the current one to the old one. Okay, but rate, rhythm, axis, hypertrophy, infarct. Rate, rhythm, axis, hypertrophy, infarct. Okay, and we talk about infarcts. Okay, do we want to really wait until we have read the whole EKG to identify infarct? No, we don't. So that is when we talk about infarct, we're trying to clarify like exactly how significant and where is this infarct located. But before we even get to that point, when we're looking at our rhythm area, we're looking for those changes of the infarct. We'll talk about that when we talk about it. The first thing we're going to talk about is rate. We know that the heart is designed to beat so many beats a minute. Okay? If it's coming from the SA node, which is our pacemaker, it's designed to beat 60 to 100 beats per minute. If for some reason that SA node isn't firing, we've got atrial rates, we've got junctional. Remember, junctional is going to be, we're going to consider our AV node, the AV node area. If that doesn't work, then it's going to go down to the ventricles. There's a lot of things that affect the heart rate. A lot of nervous system affects the heart rate. Medications affect the heart rate. Sometimes, even if the heart rate is coming from the SA node, it'll be greater than 100 or it'll be less than 60. Okay, we can have bradycardic rates are less than 60, tachycardic rates are less than 100, or greater than 100. Right, so we can still be coming from the SA node and be outside of those 60 to 100 range, but think about that as our normal heart rate, and then we have to think about why, in fact, is it higher or lower than what we would expect if it's coming from the SA node. And again, the autonomic nervous system usually plays a part in that, especially if the patient's not on any chronic medications. The autonomic nervous system affects the heart and affects the arteries, can increase the heart rate, also increase or decrease the blood pressure, can decrease the heart rate as well. Okay, the two main parts of the autonomic nervous system that we look at are our sympathetic system and our parasympathetic system. What do you guys remember about the sympathetic system? Is that up and go or is that slow and go? Up and go. That's our fight or flight, right? So fight or flight. It's going to affect usually both atria and the ventricles, and it releases this epi and norepi to increase the heart rate, increase cardiac contractility as well, right? And then sometimes it will actually increase the irritability of the heart. Okay, so which means that our SA node may be firing. If our SA node is firing appropriately, okay, but sometimes if we have increased irritability, it'll cause other areas of the heart to fire as well. So the SA node fires, we get a heartbeat down, but the ventricles might get irritated, or the atrium might get irritated. We may have beats in between our normal beats. We call them like, you might have a premature ventricular contraction, you may have a premature atrial contraction. That the SA node is still firing appropriately, but then for whatever reason the heart is irritable, and then other areas of the heart are starting to fire in addition to the SA node. Okay? The other thing we might see with this is an increase in blood pressure because we have constriction of the arteries that are associated with that release of the epinephrine and our norepinephrine. But the other part of the autonomic nervous system that can affect the heart rate is the parasympathetic system. We really think about this as the vagus nerve. Okay? The vagus nerve, and the vagus nerve affects the GI area and it affects the heart. And this is our brakes for the heart. It slows things down a little bit. So that might decrease your heart rate, decrease your blood pressure, it decreases contractility. So if a patient has a really low heart rate, when they go to stand up, they may feel lightheaded or dizzy. That may be due to the parasympathetic system. So all of that being said, we've got to figure out when they're coming in, what is this heart rate? How do we know what the rate is? Determine if the rate of their heart is the reason why they're having the signs and symptoms that they're having. Okay? So one of the first ways and one of the easier ways to identify the heart rate is we use the counting system. Okay, so with the counting system, you're going to find an R wave. So remember, R waves are our tall waves here. Okay, you're going to find an R wave, and ideally, you'll find an R wave. You've got lots to choose from, but if you can find an R wave that's on a dark black line, it tends to make this counting method a lot easier. So when you find an R wave on the dark black line, that's going to be your starting point. There's no number that's assigned to that first R wave. The next black line, the number that is assigned to that is 300, because it's 300ths of a second. Okay, the next dark black line is 150. The next dark black line is 100, and we go 75, 60, all the way down to 50. You've got to memorize that. Got to know it. So our start line, there's no number assigned. Then we go 300, 150, 100, 75, 60, 50. And there's a lot of math that you could put in to say, well, why is it? It's 300ths of a second. Okay, this is 150th of a second. Right? So we're measuring from here. So if we say this is our start line here, and we go 300, 150, 100, 75 to the next R wave, then this person's heart rate would just be just above 75, because that next R wave is our stopping point. You start an R wave here, and you go to the next R wave. That's your time. This is your beats per minute. Right? So first, you start here, and then go to this next one. Because 75 is here, it's just a little bit to the left of 75. That means your heart rate will be a little bit higher, so maybe about 77 or so for the heart rate you're counting. Yes?
I'm very confused. Is
Okay.
that like where the next peak is giving you the heart rate? Is that what you're referring to?
Right. So you have, these are all your R waves, right? This is R wave, R wave, R wave. So you go from one R wave to the very next R wave.
Okay, and then depending where it falls should be like the range of heart rate. Is that?
Yeah.
Okay, thank you.
Say that again. Ask me that again.
So like if it was where the 150 arrow is, we would assume it's around 150?
Maybe 150.
Okay.
Okay, yep. So if this R wave here was all the way right here, right next to this, that would be a heart rate of 300, right? If it was here, it'd be a heart rate of 150. Here, it'd be a heart rate of 100. Right? If it was all the way back here, it would be a heart rate of 50. Okay, so each one of these represents these different numbers. This line represents a heart rate of 300. This line represents 150, 100, 75, 60, and 50. Okay? That is one way of identifying the heart rate. Another way that you can identify a heart rate is using the 6-second method. Now, the 6-second method can be used for any EKG, but the counting method cannot. The counting method, we stop at 50, okay? So the counting method can't be used for rates that are less than 50, and it cannot be used for irregular. If you have an irregular rhythm, you cannot use the counting method, because it depends on which R to R you choose will vary in the heart rate. So the 6-second method can be used for any ECG, any rhythm, but must be used for rates less than 50 or irregular rhythms. Okay? And to use the 6-second method, you've got to first determine you've got to find your 3-second mark. So each ECG has these little tick marks. And our ECG at VMC have little arrows. And each one of those arrows determines a 3-second mark. So you're going to use this will be one 3-second, and another 3 seconds. So you're gonna do 3 of those marks, and you're gonna count the R waves or the QRS complexes in between those three, the first mark and then the third mark. So there's a total of 3 marks that you're looking at. Okay? So if we look here, we've got a mark here, there's our second mark and our third mark. So this is 3 seconds here, and this is 3 seconds here. And you're gonna take the number of those QRS complexes, the number of R waves, and you're gonna multiply it by 10, because it's beats per minute. How many beats do we have in 60 seconds? 6 times 10 is 60, right? So what would we have here? We have 1, we have 2, we have 3, so our heart rate would be 30. Hey, come over here, we have the same thing. So we're gonna do 3 marks, 1, 2, 3 marks. So we're gonna determine the amount or the number of QRS complexes in between those 3 marks. We have 3 seconds here and 3 seconds here. That gives us 6 seconds. We have 1, 2, 3. Okay, and this one falls just outside. So what do you think your rate would be for that? Almost 40, not quite, we're 30 in a possible, right? Anybody from Michigan? Yeah. Did you ever play euchre? Yeah, see, and a possible. I got 3 in a possible. Oh man, that's so fun. We love euchre. Euchre and setback. No setback? No setback. Yeah, northern stuff. So this would be 3 in a possible. So 30-ish, 30, probably closer to 40, maybe 37, 38, right? And then the last way that we can estimate the rate is using the 10-second method. Okay, so if we said 6 times by 10, then we say 10, probably times it by 6, right? That gives us our 60 seconds. Again, you can use the 10-second method for any ECG, but cannot use the counting method for any. This one, you must use either for rates less than 50 or irregular, you must use either the 6 or the 10-second method. And remember, when we initially talked about the ECG itself, each snapshot, each lead gives you 2.5 seconds, but that bottom rhythm strips gives you 10 seconds. So you're going to count the number of R waves along that bottom rhythm strip, and you're going to times it by 6. Okay, so there's 10 seconds along the bottom, you times it by 6. So what would we say our rate is here? What is 42, right? Okay, because we have 7 of those, we times by 6, 42-ish, I feel like. All right, so those are your 3 ways. You've got the counting method, okay? And if you're not good at counting, then and you will have to memorize those numbers for the test. You will. In real life, you can just use the 10-second method. Just go along the bottom. Okay, sometimes you have to do it really quickly. So if you have a really fast rate and you've got, let's say there's 22 R waves and you're trying to count that. It's easier sometimes and faster just to do the counting method. Okay, especially if it's regular. Like, okay, I'm right here, I'm at 300. But otherwise, you're trying to count 30 R waves, and by the time you get to the end of that person's like, right? Because you're just going to figure out the rate. So sometimes that counting method comes into play, especially if it's a really, really fast rate, you can do it fairly quickly. Right. If you're looking at that bottom strip, okay, and that's what I would use to look for your rate, whether you use the 10-second method, okay, the 6-second method, or the counting method, I would use that bottom strip. That 10 seconds is what you want to use to get your rate. If you're looking across that entire strip and you cannot find any R wave that's on a dark black line to make things easier, you could take your calipers. Take your calipers and measure from one R to another. It doesn't matter which one, as long as it's a regular rhythm. Measure from one R to the other one. Again, this is using your counting method. And then take your calipers, and then put it up into a clean area on your ECG and put it on a dark to a dark. And then you can use that to mark it out. Does that make sense? Okay, so you just take it up, and if you have dark here, and you have here, and it's in between, take your calipers, put it up on this dark here, and then count all your dark boxes in between. And that will give you your rate. Again, that's using the counting method. if you don't find, what else you can do? Can you do if you don't find an R wave that's not a dark black line?
Boxes, maybe boxes.
You can count boxes, you can count the boxes, or to use the 10-second method, do you have to have an R wave and a dark black line? We really just have to have that if we're using the counting method. 10-second method, we don't have it. 6 seconds, we don't have it. Use a different method if you don't want. If you're like, I can't find anything, I don't want to do all that, then just use a different method. But you need to know all 3 of those methods. All right, so if we look at this, and I tell you that this is not a 6-second strip, how do I know it's not a 6-second strip?
The lines with 2 ticks.
I only got 2 ticks. I only got 2 lines. Okay, so what would our rate be for this patient?
40.
Okay, so it's going to be low, right? So if we had to, we can't really figure this out. It's not a 6-second strip. If it was a 6-second strip, it certainly makes it a lot easier, right? Because what if I say this is a 6-second strip? What's your rate?
It'll be 30.
Someone already said, right? So if this is a 6-second strip, we have 1, 2, 3, 4, and that would 4 times 10 is 40. Otherwise, what would you, if you use your counting method, 300, 150, 100, 75, 60, 50, 54 or so, 55, right? So 300, 100, 150, 100, 75, 60, 50, so we're just above that. So that's what we, so for any rate that was less than 60 is going to be bradycardic, but you can still use that counting method all the way down to a rate of 50, as long as it's regular. All right, what about this? Okay, what about this rate? What do we think about this rate?
Crazy.
135.
Yeah, 1/3. So we got 300. Okay, so remember that first one that's our start point. There's no number assigned. 300, 150, 100. So it's between 100 and 150. It's closer to that 150. So this is an estimation, right? So we're 130s or so, maybe mid 130s. And we're not, because does it matter if this is 130 or 140? No, but it matters if it's 130 or 200. So you can't be that far out. But if you're off by 10, it's not going to matter all that much. So this is a rate estimation. It doesn't have to be perfect. And yes, the ECG machine at the top does tell you the rate. But here's the problem. Sometimes, especially if that patient has like a tremor or something, it picks up all of that, and it's going to give you a rate of 200. But then you're looking at that ECG and you're like, there's no way, because it's picking up those tremors and it's giving you an abnormal false rate. That's why it's important for you to be able to determine the rate yourself, because sometimes the ECG machines will pick up, or if they have a nerve stimulator in, something like that, it'll pick that up, and then it'll give you a false rate. Okay. So if you're calculating the rate, and we're using the numbers method, the counting method, what numbers is it associated with? A, B, C, D, or E? B, right? 300, 150, 100, 75, 60, 50. Okay, if you have 3.5 beats on a 6-second strip, mechanics. Yes. 3.5 beats on a 6-second strip. Just think about 6. What are we going to do with that 6? What are we going to times it by? 10. So 35. Yep. Just think. We want to equal 60. We want to equal 60. We got to equal 60. So if it's a 10-second strip, it's times 6. If it's 6, it's times 10. We got to equal 60 because that's 60 seconds, and this is beats per minute. So 35. Very good. Okay. What about McReynolds? We got 12 R waves on a 10-second strip.
8, 72.
72, right? because we're doing 12 times. Almost let it go. 12 times 6, which is? 72. Yes. So I know I can see you guys like, oh my God, on the test, I'm going to have to do this. Well, you are, but if you raise your hand and say, can I use my calculator? I'll let you use your calculator. Like, I don't care. You just got to figure it out. Why? It's not my fault you can't do math. It's not my fault. What? What happened?
You got it right.
Yeah, he got it right. Yeah, he got it right. Yeah. But I can tell, not him, but I can tell everybody's mind is going, am I gonna have to count these numbers? Am I gonna have to times this? You are gonna have to do that. You're gonna have to do it, but I'll get through it. You just say, can I use my calculator for a second now? I say, yes, you can use your calculator. Actually, Dr. DeBoer is gonna be the proctor for that, so I'll let you know, he knows that already. Okay, that's all for rate. Rate. We've got a counting method. We've got a 6-second method and 10-second. You need to know for 10 and 6 seconds, okay, that they can be used for anything, and then they must be used for irregular rhythms or rates less than 50. Counting method cannot be used for those things. Counting method is for regular rhythms and rates greater than 50. Okay, so you've got to know that. All right, let's talk about real quickly into rhythms. Okay, our TLOs and our ELOs. So again, we're going to our deliberate approach. Yes?
For the 10-second rhythm strip, would we know it's a 10-second rhythm strip if it's a 12 lead?
Yes.
Okay.
If you have a 12 lead ECG, which you will, you know it's 10 seconds. Always, 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 always.
Is there only one test of EKG then that we're having? So it's all these classes and then one test of EKG?
Yeah.
Okay.
Ish. Meaning, yes, from what I teach. But then Dr. DeBoer, you guys do a bunch of cardiology stuff, and his last test has a bunch of EKGs and EKG things in there. But he talks more about like algorithm approach and stuff like that. But you'll see some EKGs here. But all these classes are tied to one test. Yes. And in the 6-second, if there's a 6-second strip on there, you'll see your 3 marks. Okay, so it'll be odds. But if you see a 12-lead ECG on there, that bottom strip is 10 seconds every single time. Every single time is 10 seconds. So just equate that bottom rhythm strip to 10 seconds. All right, we're going to continue with our deliberate approach. We've got our rate. We're going to determine our rate. And the reason why rate is really important is because although when someone has a myocardial infarction, okay, someone's having a heart attack, and that's super scary, and that people die from that, right? But can you die even quicker from a rate problem?
Yes.
You can. Again, someone comes in with a rate of 350, that's not sustainable. Someone comes in with a rate of 20, that's not sustainable. So that's why we don't look immediately like, okay, do they have an infarct? We're going to look, okay, how fast is this? How slow is this? Okay? And then I'm going to move my eyes to these portions of the rhythm. Okay, the portion of the rhythm that we know. Because rhythm is not just, is it fast, is it slow, and then is it regular or irregular? That's not just your rhythm. Rhythm has a whole lot of components to it. Okay? So when we look at the rhythm, the first thing again we're going to do is look at that rate. Is it fast or slow? The rhythm, is it regular or irregular? We need to know that. Okay? Because is this a regular wide complex tachycardia, which means this person's in VTach? Well, yeah, they may be having an infarct that's associated with that, but I've got to address this VTach, or they're not even going to get to the cardiology suite, right? So that's why we got to identify that. Is it regular or irregular? And if it's irregular, is it irregularly irregular? It means there's no rhyme or reason. It's like da 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 da. Okay, or is it da 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 da? Okay, how irregular is it? Is it irregular, irregular? We've got to look at our QRS complexes. Are they wide or are they narrow? Are they wide or are they narrow? Do I have P waves that are associated with each one of my QRS complexes? Okay, are the QRS complexes grouped or not grouped together? Okay, in other words, I have a bigeminy or a trigeminy where I see two QRSs, then a space, and two QRSs, and then a space. Okay, and are there any dropped QRS complexes? I have a P wave, but I have no QRS complex. What happened to it? Where'd it go? I need to be able to figure that out. Okay, the next thing I'm going to look at is my ST segments. Okay, is the ST segment elevated or is it depressed? Okay, that's all I need to know. Is it elevated or depressed? That baseline. Okay, we've got to look at our P waves. Do I have P waves? Are P waves all look the same? Because if they don't, it tells me something's going on with the atria. Okay, and again, do each of the QRS complexes have a P wave before them? Okay. We've got to look at our T waves. Are they asymmetric? Because should they be asymmetric or symmetric, our T waves? T waves should be asymmetric. Okay, they should be kind of slow up and then quicker down. Okay, and are they upright? Are they flat? Are they inverted? Okay, normally we think upright, flat or inverted. We think about more of a ischemia process. We've got to look at our intervals, our PR interval. Is it normal or is it prolonged? And then are they constant? In other words, is a PR interval constant between this PR interval compared to the next PR interval compared to the next? Or is it variable, or are they getting longer and longer and longer and longer? And then we've got to look at our QT interval as well. Is it prolonged or is it shortened for our QT interval? So those are all the things. So when you look at your rate, the next thing you're going to do is look at your rhythm. Okay? In every ECG, you should do this. And when you're looking at your rhythm, you're looking for all of these things every single time. Okay? You've got to think about, you've got to memorize all of these things that you're looking at. Okay? So again, we're looking at that rate. Is it fast? Okay, we can see like I have a little bit of faster rate here. So 300, 150, and that's pretty fast. And just a little bit less than 150. Or is it slow? And we can see here, it's a little bit slower. Okay. Is it regular? So this is fast, and does it look regular? So we can take our calipers, we can put it on this R wave, one point, and one point on this R wave, and then we can just measure each R wave. Right? Because sometimes you'll look at it and go, man, it looks a little off. It looks a little off. And sometimes like you can look at it and like, oh, that's obviously off. So sometimes there's little subtle differences. You can measure those if you have any question or concern. Okay? Same thing here. Does this look regular? If we go beat to beat to beat, it looks like there's about the same amount of boxes, but if you're concerned, you can either count the boxes in between, but you can put your calipers on here and make sure. I would put my caliper here, and then I would keep this one in place, and I would swing my caliper over, and swing my caliper over. And I should never have to change that caliper if it's regular. Okay, so I'm going to keep it hinged in one. Swing it over, keep it hinged there, swing it over. All of those should all march out. Okay, what about this bottom one? That look irregular, right? So those are regular, but this looks irregular. There's definitely something wrong. This space looks way bigger than this space, and that looks different than this space, but this space and this space look similar, but this is irregular. So if you had a rhythm like that, how would you count, how would you identify the rate? What methods would you use?
6 seconds, 6 seconds.
10 second or 6 second. 10 second or 6 seconds. So that's what we want to do. Fast, rate, fast or slow, is it regular or irregular? And again, when you're trying to determine if that rate is regular, use your calipers. If you really can't figure it out, use your calipers. It's a lot faster than counting the boxes in between. I'm telling you, get it to box number 3, and then you're like, oh my God, where was I at? And you start over again. By the time you get it done, you've given up. So just do this walking the calipers. It's a lot easier. And that's why I say when you go to phase 2, you really need to have those calipers. I use them a lot in phase 2. Okay. QRS complexes. Okay. Are the QRS complexes narrow, like we see here, or normal? Okay, remember, less than 0.12 or 3 boxes. Okay, or are they wide? Okay. Okay, here we go. We got a wide one here, and this is wide too, because if we start from the Q, We got our R and our S. Before that S comes back up to baseline, it's all the way over here. So that's a wide complex QRS. Okay, greater than 3 small boxes. Okay, and then are the QRS complexes grouped like we see here? We've got a group here. So we've got 1, 2, and then we've got a space. We've got 1, 2, and then we have a space. 1, 2, and then we don't know what's going on here. But those are grouped together. We call that bigeminy. Sometimes you can have 3 of those and then a space. But if they're grouped together, that could indicate some sort of cardiac irritability that is going on. Okay, and then we want to find out, when we're looking, we can look here. We've got PQRST, PQRST. We have a P, but we're missing something here. We've got a dropped QRS complex. Why is that QRS complex? What causes that QRS complex to be dropped? Some sort of AV block. Something is not going from the atria down to the ventricles. Because if you have a P wave, then we know the atria are firing. But if we don't have a QRS complex, we know the ventricles are not firing. And then what happens, the body realizes it resets, and it goes back to your PQRST, PQRST, and we've got to drop it again. There's some sort of block that's preventing that depolarization down to the ventricles. So those are things you got to look at. Okay? And the next thing we're going to do, we're going to analyze the ST segments. And look at those ST segments. Ideally, those ST segments, or that J point, is going to be at baseline. Okay, so this top one, we can see we've got a little bit of our PR interval, or our PR segment here, that's our baseline. And then we've got ST segments, so that's our baseline. Or is it elevated above baseline, or is it below baseline? And what I am doing when I'm reading these ECGs, and again, I'm looking at that rhythm strip. And I'm looking at that rhythm strip for my rate. I'm looking at that rhythm strip for my rhythm. And I'm looking to see, do I have any QRS complexes? What do they look like? Are they wide? Are they narrow? Are they dropped? Are they grouped? I'm looking at my rhythm strip for all of that. When it comes to my ST segments, okay, now I've got to take my eyes and move them up. And I've got to look at the rest of my ECG, because I may not be able to get that just from my lead 2. Because lead 2 doesn't have anything to do with the lateral part of the heart, or the anterior part of the heart, the septal part of the heart. Okay, so I've got to move my eyes up. And when I move my eyes up, I'm going to put likes with likes. Meaning, I'm looking at 2, 3, and AVL together. I'm looking at 1, AVL, and come over here, 5, 6. I'm grouping that together. V1, V2, V3, V4, because those are your lights. Those are looking at the same part of the heart. If you instead look, I'm looking down this column, then the next column, then the next column, you are going to forget, by the time you get over V5 and V6, you're going to forget what you saw at 1 in AVL. All right, so you've got to put likes with likes and see, why is 1 AVL looks a little off, 5 and 6 look okay. Maybe this is an infarct that is just now happening. I'm repeating that ECG in 15 minutes and see what my 5 and 6 look like. But put likes with likes when you're looking for these ST segment changes. Okay, we've got to look at those P waves. Okay, are there P waves? What do they look like? Okay, do they all look the same? Every P wave, if it's coming from the SA node, should look the same. Okay, if it's coming from somewhere else, somewhere other foci in the atria, it's going to look different. Okay, and does each P wave have a QRS that follows it? If not, we've got some sort of block that's going on. And we also want to look at that PR interval. And the PR interval, is it constant or is it prolonging? Okay? And you can look at that now, or you can wait to look at it when you look at your QT interval. Got to look at those T waves. Are they asymmetric or symmetric? Okay, are they upright? Are they flat? Are they inverted? Okay, remember, our T waves is typically less than 5 millimeters in our Lindleys and less than 10 millimeters in height in our precordial leads. Okay, so sometimes you'll see this is our normal T wave. It comes up and then goes quickly down. Okay, this is a negative T wave, so an inverted T wave. This is that tall peak with T wave that we talk about when we see like hyperkalemia. This here is a little bit wider than we would expect, and then here, very tall and very broad. Okay? When you have these ones here, this is more associated with a stroke, some sort of intracranial hemorrhage or intracranial infarct that's associated with that. But don't discount the T waves. Okay, don't discount the T waves. You got to look at those as well. Okay, how do we know? What are some indications on our ECG that our rhythm is coming from the SA node? Our primary rhythm is coming from the SA node. If we look at lead 2, okay, and we look at AVR, those are the 2 leads that you're going to look at to help you identify if this is coming from the SA node. Lead 2, your P wave should be upright. And your P wave should be upright. Okay. AVR, your P wave, right here, is typically inverted. Okay, because of the electric conduction where that positive and negative electrons are. So look for an upright P in 2, your inverted P in AVR, and then you should have your QRS complex that follows it. And that tells you right then. Now, doesn't mean you can certainly have beats in between that, but it still is coming. Your primary pacemaking for these patients is coming from your SA node. If you have an upright P in 2 and then inverted P in AVR. Okay? We've got our normal sinus rhythm again, is 60 to 100. We got bradycardic rates less than 60, and our tachycardic rates are going to give you greater than 100. But it still can be coming from the sinus node. You can have a sinus tachycardia at 120, 130, 140. Okay, so if you have a really fast rate, we got to try to identify where is this rate coming from. Do I have an indication on my ECG that it's coming from the SA node? Okay, I'm going to look at lead 2, I'm going to look at AVR, I'm going to look for those P waves. And if I can identify that this is a sinus tachycardia, it really takes a lot of weight off your chest, okay? Because you don't have to rush around. It's a sinus tachycardia. Let me treat it. Okay, is the patient febrile? Are they dehydrated? Are they anxious? Okay, let's figure out, because those are typically things that you can fix. Okay, but if this is an SVT, meaning I don't see those P waves, or this is an A flutter, then I'm going to need to do some action pretty darn quickly to be able to manage these patients. Yes.
Whenever the ECG, I don't understand obviously on the machine so well, but is the rate one of the metrics that determines whether or not it says normal or abnormal sinus rhythm? Do you understand what I'm saying? So if it was under 60,
Yep.
right, you had somebody with like 45.
Yep.
Would that ECG read, because ones that I've seen say normal or abnormal sinus rhythm?
Yeah. It'll say abnormal. Yeah, it'll say abnormal.
So you'd have to like,
But it doesn't say abnormal sinus rhythm, it just says abnormal EKG or ECG. Yeah. Because if you have a bradycardic rate, that's considered abnormal. But it still doesn't tell you if it's sinus or not necessarily. At least not the one that we have. I'm sorry, it does. So it'll say normal sinus rhythm. It will say bradycardic is what it will say, or tachycardia. But it doesn't specifically say if it's a sinus rhythm when it comes out of that normal sinus rhythm. It just says like it's a tachycardia, tachycardic rate or whatever. We said, yeah. I know what you're talking about because it will say normal sinus rhythm. Yeah. All right, so this is your summary, okay? We're looking at that rate, we're looking at the rhythm, looking at our QRS boxes, QRS complexes, are they wide or narrow? Look at the ST segment, so now take your eyes off the rhythm strip, go up to the main, okay? Then come back down, look at your P waves, are they upright in 2, down in AVR, that tells us it's coming from the SA node. Do I have my PQRST? We're gonna look at those T waves. Gotta look at the PR segment, 3 to 5 boxes. Is it prolonged? Is it constant? Is it getting longer and longer, or is it variable? And then we got to look at that QT interval, less than half of the R to R interval. All right, why don't you guys take a break, and then we'll spend a couple more minutes just kind of reviewing some of these rates.
That's a puzzle. Yeah, I was okay. That's what it was.
Oh, yeah. So you can change your paper speed. How fast you go from underneath 10 to 50 millimeter per second, so 25 millimeters. Gotta go into the settings, we can change it to 50, and it slows it down. All right, so 25. The first thing we're gonna look at is our rate. Look at our rate. So, what do you think the rate is? Let's go with Mitchell. Mitchell? Mitchell? Okay, sir, there you are. You were, last time it was over here. Okay, what's your rate? $66. And how did you determine that? What's that? 10-second method? Okay, 10-second method, 66. Does anybody get anything different? Okay, so you can use that 10-second method. Could you use the counting method?
Yes.
Yeah, you could use the counting method as well. Mitchell? I know, right? Watch out. Yeah, so you could use the counting method. If you did the counting method, this falls right on black line 300, 150, 100, 75, 60. So, yeah, right on, right? So that's 65. You're using the counting method. All right, very good. Rhythm. What do we say our rhythm is, Elliot? Regular or irregular? That's all we gotta know. Regular? Where you at, Elliot? There you go. What do you say? Looks pretty regular, right? Looks pretty regular. Okay, what's the next thing we do? We got rate. We got rhythm. Is it regular or irregular? What's the next thing we look at? QRS complexes. Are they wide or narrow? Yeah, look narrow, right? Less than 3 boxes, that's normal. Okay? What else we want to know? So QRS, we want to think about QRS complexes.
ST segment.
Well, what else we have to know about the just in relation to the QRS?
Oh,
Want to know if they
are they grouped or not grouped?
grouped or not grouped? Okay? Is there any dropped QRS complexes? Do we have a P before each QRS? Okay, or I should say a QRS after each P, right? So drop complex. So we don't see anything grouped. Okay, we don't see any drop, looks pretty regular, so we don't see any drop complexes, which we identify with our regular rhythm, right? So then the next thing we'll do is our ST segments. So again, I'm taking my eyes off this bottom strip now, and I'm coming up. I'm looking at 1, I'm looking at ABL, I'm looking at 5 and 6. I'm looking for ST segment elevation or ST segment depression. Then I'm going 2, 3, ABF. V1, V2, V3, V4, and I'm done. It shouldn't take really more than about 10 seconds to scan up real quick, because most of the time, it's fairly obvious if you've got ST segment elevation depression. Sometimes it's not. If it's only like right at that 2 millimeters, you're like, oh my gosh. And then you have to look. Yes, sir?
Where do we know where each lead reading begins? So how do I know where AVR starts and where it ends?
You can tell the difference in the amplitude of your QRS complexes. So here, you can see you've got 3 beats here, but then this amplitude completely changes. So pretty much where that AVR, AVL, AVF is at, that little space, that's where you're transitioning over. Okay, so here, right where that V1, V2, V3 is, that's where you're transitioning over. So you look over here, this will be your first beats for that. Sometimes you'll get a beat that's kind of right at that transition, and you want to kind of discard that beat. You want to look for the next beat, because that's just getting at the very end or beginning of that electric reduction. Okay, so that's all we have for ST segments. What's the next thing we look at? What's that? Key wave? Key wave? Key wave? Keys, right? So are they asymmetrically? Okay, are they symmetric? Are they flat? Are they inverted? So what do we think about these T waves?
Look pretty good.
I mean, they look pretty nice. Those are real nice T waves. They come up and then straight down, then up and then down. That was real nice T waves. Okay, and so I kind of look all over. I look at all my T waves, make sure they're all good. All right. Then the next thing we want to look at is our P waves. Okay, so first thing we want to know, do I have P waves? Okay, looks like I have P waves. Yeah, when you're trying to identify, again, where this is coming from, you're going to look at that P wave in lead 2, look at that P wave in AVR, upright in 2, down in AVR, so that tells me it's probably coming from the SA node. And I've got to figure out, do these P waves look the same? So I can't just look at one lead, okay? So I will look primarily at my bottom rhythm strip, because if there's a problem with the atria, I'm probably going to be able to see it even in that one lead, but I've got to look at other little leads as well. So I'm going to come up and look to make sure, kind of throughout, that are my P waves looking the same pretty much. If there's a problem in P waves, you can usually figure it out in that lead down here, right at your rhythm strip, and then look at your contiguous leads up on top as well. You can look here in 3, that P waves looks a little bit different. We're looking at those contiguous leads. So look down here for your P waves and just scan real quick. If you're missing P waves, okay, if you're missing P waves, then there's a problem with atrial conduction. Something's not depolarizing the atria, which means either if you're missing all your P waves, and this is probably not coming from the SA node. If you're missing some, it can be firing from the SA node, and then some other foci in the atria or junctional area is taking over. So it's not firing normally on every single beat. Okay, after our P waves, we're going to look for our PR interval. So PR interval, you're going to measure from the beginning of the P to the beginning of your QRS complex. And again, sometimes it's pretty obvious when it's long, and sometimes it's not. Remember, greater than one big box, means it's too long. And your PR interval should march out. If you think there's a little concern, take your calipers. Put it on your first one, then move that to the next one, move that to the next one, move that. They should all march out. Okay, and then the last thing we're going to look at is that QT interval. It should be less than half of the R to R. Beginning of the Q to the end of the T should be less than half of your R to R. And then remember, for timing purposes, okay, for males, 350 to 450, and females, 360 to 460 for your time. So that's every single ECG. Every single one, you've got to do that. Okay? And again, when we talk about the exam, figure out what your answers are. Know the question, figure out what your answers are, then read your STEM. Your STEM is going to give you information like this. Person that has hypertension. Okay, if they have hypertension, I'm telling you they have hypertension. Okay, they're coming in with dizziness, shortness of breath. If I'm telling you they're having hypertension, it's probably going to be affecting the left side of the heart. If I tell you you have the pulmonary hypertension, it's probably something that's going to be on the right side of the heart. Okay, so those are the things that you'll get those clues in the STEM to help you focus on if it's going to be right-sided or left-sided. Right. All right, so let's go through a few knowledge checks for our rate. Let's start with Britman.
Yes.
Okay, Joseph Britman. What do we have for our rate? We have 5 RAs on a 6-second strip.
That'll be 50 beats per minute.
50. Ready? Okay, very good. Anybody disagree? So 5 times 10, it's going to be 50. Very good. All right, so these become a little bit more difficult. For the rate in A. Who's it? Yeah, how do you know? What'd you use?
It's the 10-second strip. So
Counting method, right? So do you have to use the counting method for every one of these? Yeah, you kind of do, right? Because we don't have 10 seconds and we have nothing to do at 6 seconds, so you kind of do. Here you go, sir. What about Bravo? What do we got? Yeah, so what oftentimes confuses people when they're looking at Bravo is like, wait a minute, I'm supposed to be counting from up here. Doesn't matter. You can count from down here as well. This falls right on the line. You just count from here. It's okay. If you want to count from here, you can. It's not going to be any different, but it's a lot easier to count from where you have a point. This kind of is more broad up here. So we go 300, 150. Okay, what about Charlie? 300, 150, 100, 75, and 60. Okay, and then Delta. Man, these are amazing. They all fall right on the line. 75, right? 300, 150, 100, 75. Okay? Are we doing okay so far? Yes, sir.
Ma'am, can you explain Bravo for me, please? There's some confusion.
So when this is a really fast rate, right? And so this is going to be, do you think this is, depending on what lead we're looking at, okay, that's the other thing, if this is ADR, it's a little bit different. But otherwise, you would probably consider this more like a QS, right? Because we don't really see we don't have an upright deflection. This is probably your T wave here, and it's coming down directly into a QS, and the T wave's up here, okay, as opposed to an R wave coming down into your QRS. Because R wave, even if it's broad, you're still gonna have a point to your R wave. There's a super fast rate, and this, this could be something like even a ventricular tachycardia, only it's not quite wide enough. Your wide is up here. But this is going to be your T, and it's going directly down into your QS complex. All right, what about number 1? Tate.
It's 30, ma'am.
30. How come? How'd you get it?
It's the 6-second method, 3 times 10.
6 second. And you know you can use 6 seconds because?
There are the,
Oh, sorry, that was a little off. A little bit.
because there are the 3-second intervals.
Yeah, you got your tick marks. Okay, you got 3 of them, and there's 3 of these. You're timing it by 10. Okay, and that gives you your 30. What about number 2, Tate?
That is 50.
1, 2, 3, 4, 5, and then number 3.
60.
Oh, 1, 2, 3, 4, 5, 6. Okay, everybody got that? Understand that? Could you use the counting method for these? The first one you really can't, right? Because we're going to be stuck at 50. Okay, the second one you could. Okay, you could use accounting, but we can't really, it's not really easy to determine your 300, 150, 100, 75, 60, and that gives you just below 50, right? And then you can use it for this. But if you have those tick marks, it's fairly easy to use your 6-second mark and then times it by 10. And again, on your ECG, if I give you a 12-lead ECG, you can use that strip at the bottom, but also on every one of those ECGs, okay, in real life, you're gonna have these tick marks, or you're gonna have 3 and 6 and 3-second marks on those ECGs. Alrighty, let's go with Kenfield?
Yes.
Yes. What's her rate?
Around 140.
Around 140, okay? And how did you get that rate? You did what?
Counting method.
County method, right? Because we don't really have much of a choice. And so if we find one that's about, this is about on a dark black line, 300, 150, okay? So this is up a little bit, so yeah, we got about 150 or so for our rate. Does everybody see how we got that? Okay, here you go, sir. All right. And then we're almost done here. Let's go with Buchanan.
Let's go.
Buchanan, what we got for our rate? Where's Buchanan?
Right.
Oh, there you are. Are they clowning on you over there? That being mean?
There you are. For 66.
What method you use? 10-second counting method? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 times 6. 66, here goes, sir. 66. Anybody use any other method? Okay, what if you used, well, you can't really see. Okay, what if you used a counting method? 300, 150, 100, 75, 60, 66. So you could do, if you do the 10-second, you know, times that by what? 6. Okay? And if you use a counting method, you're just going to count the 300, 150, 175, 60, 150. Okay. All right, and this is, I think, is our last one. So who gets the last one? Ooh. Is it Papaneer?
That's me.
Is that how you say it?
Have it here, yeah.
Papaneer? Okay, ma'am, what you got? How many arm waves you got across the bottom?
22.
22? 22 times? 6? 132, right? Can you use any other method besides your 10 seconds? No, why? It's irregular. Oh, you guys are doing so good. All right, I think that's it. All righty, see you tomorrow.
Thank you, ma'am.